morning, good afternoon, and good evening to everyone who's joining us on the call today. Welcome to another great week of the Global Cafe sessions. And my name is Roxana, as Ashley mentioned, and today I'm very excited to be introducing you all to Professor Heather Keller for the topic of improving the health and quality of life of older adults through food and shared meals. Now, before getting started, as a little bit of background for everyone, Heather is a professor and the research chair in nutrition and aging at the University of Waterloo and the Research Institute for Aging. Her research areas and focus are quite vast, and they include nutrition risk and malnutrition identification and treatment across care sectors, improving nutrition care processes and implementing screening and other best practices, supporting food intake of diverse groups living in the community, including those living with dementia, as well as improving hospital and residential food, as well and promoting food intake and the experience in these settings. So Heather has led several national research and knowledge translation projects, and as a founding member and past chair of the Canadian Malnutrition Task Force, she is involved in translating research into practice and advocating for improvements in nutrition care for Canadians. So thank you, Heather, for all that you do. And I guess now to really just hand the floor over to you, can you actually tell us all a little about yourself?
Sure.
Being recognized as an international expert in geriatric nutrition, assessment, and treatment, in addition to all your work and research, is truly a very remarkable achievement. So could you further elaborate on how your professional and personal journey led you to where you are today?
Oh, yeah, been a long journey, that's for sure. I guess when I was in high school, I'm thinking about where to go next. My mom, who never went to university, my father never went to university. Actually, my dad didn't even go to high school. They were much older. My dad was almost 50 when I was born, actually, and my mom was in her 40s. And they said, do either healthcare or teaching, one or the other. That way you'll get a job, right? And so I knew I didn't want to be a nurse, and I thought this nutrition thing was kind of interesting. I'd worked in restaurants all my life, and food was a big part of our family. They were farmers, past farmers, my parents, so food was it. And then I realized this research thing was really actually quite engaging. I, I liked asking questions and answering them rather than just learning what to do. Wanted to find out new information, right? And I was at the University of Guelph, and fortunately at that time there was a geriatric research center, and I always thought older adults was a niche that I really welcomed. I was comfortable around older people. My parents were older. All my colleagues were interested in pediatrics and working in clinical hospital sort of settings. And I thought, no, I want to work in the community with older adults. And so I sort of pursued my studies that way, and quite frankly, fell into a variety of opportunities that led me here. For example, I didn't want to be a clinical dietitian, but my first job was being a clinical dietitian, because it was back in the time when it was the early 90s here in Ontario, and there were real challenges with getting any public health job, any job in public sector at all. And the only job that came up was a maternity leave in a geriatric hospital. I thought, well, at least it's geriatrics, so I'll do that. And that's where I started doing research as part of my job, and found the power of doing research. You could change things. I thought, this is what I need to be doing. So I pursued a PhD, and then really got into the academic setting after that.
Thank you very much. And I love what you just said. Research is quite powerful, and it does have the ability to change a lot. And I guess going back to the topic at hand, which is to discuss how we can improve the health and quality of life of older adults through food and shared meals. Could you share with us some factors associated with the development of high nutrition risk, and what they are and could be, particularly in the context of healthy aging?
Sure. So as we age, things start to change for us, right? And I can see them in myself already. I'm closing in on 60. Things like balance change, your ability to function the way that you did when you're younger changes. So carrying groceries, challenges with starting to not being able to drive in the same capacity as you had before. So transportation changes. We often see a lot of life changes as well around a person when they're aging, moving into retirement, for example, loss of a spouse, beginning to live alone if they weren't living alone before. Health conditions start to mount up and change our capacity perhaps to stand and cook a meal, or our energy to cook a meal. So all those sorts of things mount up as we age. We know that older adults who are at nutrition risk tend to be older, so over the age of 75 especially, tend to be women, tend to be individuals who start to have challenges with function, using a cane, using a walker, having some form of disability, maybe it's hearing or seeing. Those things affect our ability to access food, prepare food, consume food. And that's where nutrition risk comes in. Then there's the psychosocial factors. I said, living alone. It's not easy to be motivated, quite frankly, all of your life to eat good meals when you're alone. And as we get older, we might find that we can't eat out as often because of challenges. It might be gastrointestinal challenges. It might be dentition. It might be swallowing. It might be economics. We can't afford to eat out with friends as often, right? And so we're eating alone more often. And that tends to be then, if you're not very conscious of making meals, it can then become a challenge to eat a nutritious diet. So there's a variety of psychosocial and physical risk factors that I would say that can play into being at nutrition risk. But we do know that it's prevalent, right? As people get older, nutrition risk becomes more and more of a challenge, and our body's ability to use the nutrients changes as well. And so we have to actually have a more nutritious diet as we get older, unfortunately, to get that bang of the nutrition that we need to keep our body healthy.
Thank you very much for that. And as part of your research areas, one area does include supporting the food intake of diverse groups living in the community, including those living with dementia. And of course, designing dementia inclusive spaces includes the focus area of food, nutrition, and meal preparation. So, can you elaborate on how
Mhm.
your work has led to supporting the food intake of diverse groups in this community and also including persons with dementia?
Sure. Yeah, and so I think the most recent project specifically is called Dream, and it's one of the links that we actually have for some of the resources. This is for dementia resources for eating and activity for older adults who have dementia. And it's actually designed as well for people that might be providing a program in the community. So it has a provider section and a section as well for persons living with dementia or their care partners or caregivers. And that section that's on the provider section talks about inclusivity and the importance of including individuals in exercise and food and nutrition programs in the community for old adults. I think of things like a congregate meal program. Churches might run a meal program, and older adults might have dementia, or an exercise class. And so how can we make sure that the folks that are running those programs that are not healthcare professionals have an understanding of dementia and the importance of inclusion of individuals with dementia? So that's part of that training. But in addition, there's this segment on exercise and what exercise can look like. And it's not necessarily just about physical functioning, but inclusion and social interaction that happens with exercise. And so we talk about that. And then, of course, my area, which is the eating part. And so we talk about the importance of a healthy diet, but also the idea of shared meals, this idea that when we eat with others, it actually supports our food intake, but also supports our psychological well-being. Right. And so how can we support shared meals when someone is living with memory changes or dementia? And there's even some handouts there for caregivers and for providers about when people start to have challenges around food and eating. For example, swallowing problems, chewing problems, or they might have challenges specific to dementia as well, such as having a hard time attending to the meal, staying at the meal because their attention wanders and then they leave the meal. So how can we help address some of those and support the individual as well as possible? That's probably the most recent and most expansive program that I've been involved in that includes a diverse group of older adults. I think the other thing that I've done in the community that it may not be necessarily a program, but thinking about how to identify this nutrition risk in older adults in the community, because that identification by service providers and healthcare providers then leads to meeting those needs in some shape or form. And so I spent a lot of my career trying to develop and validate tools that can identify nutrition risk easily, that people can self-administer. For example, creating then the supports to healthcare professionals and service providers about what to do next, supporting the development of fact sheets for older adults. So if they're losing weight, what are some key tips that they can think about that can support their health? And so again, some of those resources are available in the chat. And so that helps diverse older adults, certainly in the community. I'm starting to move into that cultural space now as well. Canada's getting very multicultural, and not in the community living sector, but specifically in the long-term care, senior living space. I have some students working on how can we make sure menus and the food that's provided is culturally appropriate, because food is so incredibly important to who we are, right? I can imagine if you're moving into a seniors living environment and your foods are not represented in that menu, and how that isn't welcoming to you, then you're not very satisfied with that environment. And then secondly, thinking about how do we even measure satisfaction around cultural foods in that environment. There's no tool that I'm aware of that even measures that. So trying to help skill, I guess, would be the word I would say, and help support providers realize they've got a challenge here they need to address and start addressing that.
Thank you. And you're right, food really is central to self-identification as well, and it is a big factor of it. Do you see this shifting a little bit more in the sense of this cultural aspect of food being more diversified in a lot of these settings?
I think there's a recognition of it now, but that
Okay.
people aren't sure what to do. And so my one PhD student right now is actually talking to dietitians specifically and ask them, how do you manage and how do you create a menu, and food service managers, and they don't have a lot of tools. They haven't learned it in school when they were doing this. They might be 20 years post school now. And so it's really, they have no sense of what they don't know. And so that's one of the gaps she's trying to fill with her research. She'll be working, actually doing 3 studies as part of her PhD. The second study is talking to people living in senior living environments about who are from a different from a ethnic cultural background that's not North American. And they could be European, they could be from Asia, wherever it may be, but they self-declare that their eating patterns are not like the typical Canadian would be. And then the third study she's doing is actually looking at 2 homes that have done a good job of this and trying to find out how they did it so that we can package that and support other homes to do this as well.
Thank you very much. And you mentioned the idea of shared meals supporting like mental health and well-being. Sorry. And we have Mr. Shmuel Yerushalmi, who is a consistent Global Cafe attendee, and he has a question regarding this. So could you further elaborate on how shared meals can support the development and mental health and well-being, particularly amongst older adults?
Sure. And I came into this research, quite frankly, looking at persons with dementia. I had been doing my screening tool that I created. I'd been working with a geriatrician in Guelph, Ontario, and she said, "Heather, you have to do something as well for my clients who have dementia." And I'd worked in again long-term care and nursing homes with people living with dementia, but not in the community per se at that time. This is about almost 30 years ago now. Um, and so I started into that area, and I had a master's student interview family care partners about what was important to them. So we just had 3 buckets of questions, grocery shopping, cooking, and eating meals. And where a lot of the concerns were and emotion was, it was in the eating together piece. So I thought, oh, there's something really interesting there. So I had the good fortune to get funding to do a 6-year longitudinal study of persons living with dementia and their care partners, to every year go and talk to the individual and the dyad together, the caregiver and the person with dementia, and talk about meal times and what was changing for them and how that impacted them and what they were doing to try to manage that. Not the food, just the meal. And it made us realize that the meal is incredibly important. And I think it isn't just for people living with dementia. It's made me realize the food and the way we eat together is important for our lives. And so we boiled it down to 3 concepts. It's about being connected. And so you can think about, in any family setting, eating together brings you together, right? And it acknowledges you as an individual. You feel important. You feel like you belong. Even think about it when we have guests to our home. There might be guests that we have over for coffee. There might be different guests that we have over for a meal, right? So it's a little bit different sense of belonging when you share a meal together. So that's being connected. The second was the concept that came out was, it's about honoring who we are, honoring our identity. So individuals can be expressed who they are in the meal, where they sit at the meal, what they have to eat. Maybe they have a ritual of prayer before they eat, so that it honors our identity, right? And so when our identities honored, we feel, again, a sense of belonging, well-being, that we are acknowledged as individuals, right? Which is important. And the third piece was about mealtimes help us adapt to our evolving lives. You think about your own meal, sitting down with other people, you talk, right? You get support. Maybe you're in a situation where cooking might be a challenge for you. Having someone else cooking for you, that's physical support to help you eat well, right? So there's that support, and it helps you adapt to that evolving life. We found that the caregivers themselves and the person living with dementia use the meal as a way to, one, stay connected, identity, but also help them to adapt to their life. And in fact, we realized, we call this the life nourishment theory, that really meals are microcosm of our lives, right? And so if meals are this positive sort of connected thing, then our lives are a bit richer than they would be otherwise. And so that's why we think a shared meal is really important. Where we've gone with that is thinking about in the residential, again, care space. My mom lives in long-term care. She's 98. And I see this all the time in other homes as well, that it's often the meal is treated like a task rather than an activity of joy and identity and being connected, right? And so people line up for the meal. They'll come, they'll sit quietly at their meal, they'll be fed, receive their food, and then they leave. And this incredible opportunity for social connectivity is just not there. So what can we do to change that space? And it's often things like allowing people to stay in the dining room longer. I started in this area, 30 plus years ago, and can remember nursing homes closing the doors, even putting a padlock with a chain around the door handles to keep residents out between meals. It's like, why are we doing that? We're taking this beautiful space that people see as a place to share and be with others, and we're keeping them out of it, right? And so there's things that we can do at a system level, at a home level, at a team member level, that can really make it this welcoming environment rather than rushing people through a task.
No, absolutely. And thank you very much for sharing that with us, Heather. And also thank you, Shmuel, for that incredible question. Now I see Mr. Brendan Sherlock, you post a comment in the chat. Would you like to further elaborate on that with Heather?
Yeah, I'll just have to go back to my chat and read it now. Yeah, thank you. Sorry, I was on something else. I'm involved with age-friendly scaries, and that I just got a text about it.
Okay.
Just to bring up I happened to have a visit to hospital the other week, and I was just thinking about the menu. In other words, that there's a main meal, there's soup, and there's tea. And at the particular time, I didn't feel the best. But the one thing that kept me going was the soup. And I thought to myself, well, there's a waste of the main meal.
Yeah.
But and I can understand it from, the logistics. You can't just have different things for different people, but it might be just something that the settings could think of, that they ask the people, do they want the full meal?
Yeah.
Or do they want just, you know, ABC, that a cup of tea or a bowl of soup or whatever?
Absolutely
Seems
agree.
an awful waste to me.
It is. It's a waste, and also
Yeah.
people are not getting their choice, right? And I think I've done some research around this with hospitals, and hospitals that give any kind of choice, people seem to be more satisfied with the food. But you're right that many hospitals have gone to a set menu. You get no choice. They try to make it as appealing to everybody, but that means some people are left out, right? So we know that from research that when there is any kind of choice, people are more satisfied in hospital with the food. Many hospitals, I shouldn't say many, some hospitals are starting to move to more of an a la carte menu where people can order it just before the meal or an hour and a half before the meals. Because if you just came out of surgery, for example, you're not feeling well, you don't want necessarily everything that they have on offer, right? You might not be ready to eat. Or on the flip side, I can remember a colleague of mine, he'd gone in for, I think, a hip replacement or something like that. And he was ready to eat, but there was no food available because he had his surgery late in the day. And there was no food available for him until the next day. So we need to figure out how to do food more a la carte. And so there's some hospitals I know in Canada, they're moving towards this model where people can basically call they have a phone, I guess, and they would call and indicate, I want soup for lunch, or I want soup, and it comes up, it's like a restaurant, or sorry, like a hotel to your room, right? So hotel catering sort of feel to it. And I think that's a wonderful idea, one for waste and one for meeting the needs of people. My one concern about it is if someone's in there and they're not eating well, how do we make sure we know that? And so there's got to be good processes behind that, saying, you know, person in bed number whatever actually hasn't ordered anything for 6 hours. Maybe someone should go check and see how they're doing, because they need something to eat. We know that when people don't eat in hospital, they lose muscle and they lose function very, very quickly. And so as long as there's good processes in behind it to make sure they're eating something, and then if they're not eating enough protein or calories, a dietitian's getting in there to talk to them and find out what they can and want to eat that is good choices that will support their recovery. Yeah, great idea.
Thanks very much, Brendan and Heather. I see Mr. Ken Howe. You also posed a question in the chat. May I ask you to please unmute to discuss it?
Certainly. Hello. Are you able to hear me nicely?
Yes, we are. Yeah.
Oh, thank you. Thank you. Interesting topic, Ms. Keller. We're designing and developing co-housing model, and I think it strikes on both a couple of the issues you said. Certainly community, where people are not so lonely because they eat together. Secondly, people support one another in cooking meals together, and nutrition. And I think when you cook for others, you cook a nutritious meal. Yeah. If you were to cook for yourself, yeah, what can I make that's quick and simple and less fuss and less dishes and less pots and pans? But I've not completely observed it, but I've heard about it. I didn't know whether you had actually observed it or studied it, because I would think that the community aspect is a life-giving. The biggest cause of death is loneliness in Canada, and I think we're becoming more and more lonely.
Absolutely. And there aren't a lot of co-housing options in Canada that I'm aware of yet, so I don't know of too many studies being done. I do know of the NORCs, which are naturally occurring retirement communities. Mm-hmm. And so that could be a community of houses, it could be a apartment building, condos, whatever it may be. And there is some research to suggest that in those environments, because it's more socially engaged, it can actually support people to live well. The eating part, I don't know how well they do with eating. I actually have a postdoctoral researcher right now working with me who's very interested in this topic. And we're looking for a NORC to do some work with, quite frankly, and see if putting in some of that programming like eating together once a week or that sort of thing can actually promote nutrition overall, because the person's then more interested in eating healthy or eating at all, right? I believe as well as you do that co-housing is a great opportunity, whether it's living with intergenerational family, right? And you have children to cook for, or living with a group of people in a large home, or even in a I joke with my cousins, but I have a lot of cousins. My family, my husband's family is very large. We should all have a little compound, a communal sort of building, and all our little houses around it. And I think that would benefit all of us as we get older, because I really believe in this social model. You're right, that loneliness is what kills, right? People have they have apathy for no appetite, no interest in purpose, all those sorts of things. Absolutely.
We're building a purpose-built environment. So we purchased a 50,000 square foot school in Prince Edward County. You can look us up on www. Pinecrest Housing.
Okay.
Pinecrest Housing. And to have an exercise spot, to have walking trails, food, and a commercial kitchen would all enhance that. Okay, I got off.
That's wonderful. Yep. Great.
Thank you very much, Ken, and thank you, Heather. And I know, Heather, during our discussions initially and earlier this week, we also spoke about just the importance of using nutrition to keep people aging where they want to be aging, which is a very powerful statement and relevant to today's discussion. And this leads to the question of how can we, as a society, really better connect and integrate care settings with the broader community, particularly in the context of food and nutrition?
Yeah, no, that's a great question. And, so we have these care settings, if you call them, or seniors living, right? Retirement homes, long-term care homes, community centers, a variety of things like that. We should see these as hubs, quite frankly, to the community. And so can you imagine if many retirement home now, at least in Ontario where I live, there's a lot of retirement homes, maybe not so much in other provinces, but they seem to be in almost every neighborhood. It feels like in my city anyway. That could be a hub for every other, that area around. And so you can imagine, as Ken was talking, people from the outside coming in for exercise, coming in for a meal, treating it more of it as a community center rather than just a care setting. And then the people that are living there can see them as part of the community as well, themselves as part of that community. And maybe then they would have more exposure to people living outside of their care setting. And it again gives that more vitalized feeling, I guess, to the place, right? And so I do think there's an opportunity there to think about our care spaces that we have now, whether it be nursing homes or retirement homes, as a hub for the community that can provide meals, that can provide exercise, can provide social activity, all those sorts of things for people that also live around that community center, that care space.
Thank you very much. And in the context of nutrition and food, could you speak a little on the importance of person-centered and relationship-centered approaches to care as well, and some of the fundamental skills in providing just this aspect of a person-centered approach to adapt and individualize nutrition interventions for older adults?
Sure. And I think I like the idea of relationship-centered meals, especially that shared meal that we were talking about before. And so person-centered care is where people are directing their care and they're part of all decision making. They decide what they want for themselves. And that should happen in every health encounter, quite frankly, and non-health encounter. Just because we're aging doesn't mean we don't have the capacity to make those choices, right? No matter our cognitive abilities. And so it's a huge part of the way that we should be providing care, and not paternalistic. And it's hard for hospitals and senior living and organizations to get their head around that. They're so used to knowing what to do rather than asking the patient, what do they want? What's important to them? right? And so I think we're getting there. But relationship-centered care to me is even more important, especially in a senior living environment where someone's there for a period of time, right? They're there for potentially years. This is a place that is their home, right? And so those caring relationships should be relationships, not just I'm the care provider, you're the client, and this is what's happening between us. It's really about relationships. I've seen this again with my mom and her long-term care home. She has certain care providers that she loves, quite frankly. And when they're on shift, they have a great time together. And then there's others that are not so close to her. How can we actually build those relationships? Again, it's all about relationships. It's relationships with me as her daughter, care provider outside of the home, my relationship with her and with the team members, and then the team members with her and with me. And that's the relationship that's going to really help her care best, right? And when she starts to lose capacity for decision making, they need to know her well, and they need to respect what she would want, and also know me well, right, in supporting that care. And that's what relationship-centered care is about, this idea that the relationship itself is important, and how do we nurture the relationship. So thinking about care environments, it takes time, right, to build relationships. But thinking simply about the meals, for example, could we have designated, many homes have full-time staff on a neighborhood that they are working on, right? Could we now then, let's have people that always are the consistent caregivers for those individual clients, right? So there isn't always a switching around. And so then there's this opportunity to build these relationships, right? And so, you know, Sally's on and she's working with Marg, and they have a great relationship. They work well together. Whereas Marg, when Sally's not there, doesn't do as well, because Sally knows exactly how Marg likes her tea and how she likes to be assisted, right? I see some nods going on with heads on the space here. So that's what relationship-centered care about, is knowing the person so well and building relationship with them, you know, feeling like they're part of your family, in essence, is what we're trying to get towards. That's probably not totally achievable in all settings, but that's where we want to go. And so rather, again, thinking of a client and a task as a thing to be done, it's this, we're doing this together, right? This is who we are, and we're working together to achieve this end. So how do we get there? Yeah, that was your other part of your question, Roxana. That's the tricky bit. And, you know, I'll focus in on meals because that's what I do, right? And I've heard folks working in this sector say meals are actually the hardest thing, because you have a large group of people, often, you know, 30 people or so, coming to the dining room at once, all wanting to eat. How do we build relationships there, right? And so again, it's time. We seem to have timed our meals in these senior living settings that it's, you know, from 8 to 8:45, this is what happens, right? And then you rush people out because we got to get the dishes done. Okay, let's get rid of those rules about time. No one does that in their own home. They're not down to the minute about when they're doing the dishes. Let's loosen up some of those boundaries, if you will, because that's going to allow us to have time for relationship. And then make it an expectation for staff that relationships are what we do. So rather than standing to the side and watching people eat, sit down with them, right? Sit down with them. If no one needs assistance, you can sit at the table and have a conversation, right? It's not intruding. If they want that sort of, you're a person who actually lives outside of this care home, you can bring some interesting knowledge from the outside to them, or you can talk about the news, whatever it may be, right? And that's about, again, building relationship. My mom, when she has a good, she calls me every day. I can tell when she's had a good day, she's had that relationship building happening, right? And other days when it's not so good, she's been treated like a task. And so we want to have those good days more often than those bad days.
Thank you for that. And I just also want to recognize everyone who's posted comments, questions in the chats. Thank you, everyone. And I encourage folks to please put your questions in the chat. And I see one from Miss Denise Wang. So Denise, can I ask you to unmute to speak a little bit more on that? I'm sorry, I don't believe we have your audio. I can ask your question as well if,
That's
oh,
fine.
we hear you now, actually.
Okay. Sorry for the delay. My question was, what are your thoughts about medication, overlapping medication routines with meal times?
Yeah. You know, when we're in our own homes, we might take medication at meals because that's how it's done, but it's very discreet, right? Versus in a care setting, again, we know now we have 30 people getting drugs, and there's a big medical cart that maybe makes noise, and when they're crushing the meds, that changes the mealtime environment. Now it's very institutional feeling, right? And so I've been to other countries where it's very discreet again. I think it was Sweden actually I was in. They had sort of a home model. They had, I think it was only 12 people on the neighborhood. And in each residence room, they had a locked cabinet with their medications. And the care provider would come in before the meal. If the person happened to be in the room, they would give them the meds right there. So they weren't in a big med cart being rolled around. If the person was already in the lounge waiting for the meal, they would go to that little locked cabinet again, get the pills out and bring them to discreetly and have them with water. No big med cart. So making it more like that is what we need to do. I recognize that some medications have to be provided at meals, and it's certainly part of the routine to do it at meals. It's a time when, doctors say, 3 times a day, let's do it with meals or whatever, right? It's a built-in routine. That's why we do it that way. But can we deinstitutionalize some of it and keep the med cart for sure out of the dining room and the noise that goes along with it?
Yeah, the medication cart is one issue that I've noticed, but I mean, specifically in dementia care, there's a lot of issues related to swallowing. So
Right.
trying to hide medication in
Oh, okay.
or in a dessert or something, or asking them to eat a sweet pudding
Yeah.
that has their medication mixed in it while they're just eating their mashed potatoes. I mean, for a lot of people,
Yeah, that's
is very, very
exactly.
different.
Yeah, and so that is not person-centered, right? That's us prioritizing the task over the person. And so if we know that they only will take it with sweet, then let's wait till the pudding comes and let's do it then, right? Yeah.
Or the observing, that's the other thing, is like the med cards, right? There's a rule that the person administering meds has to watch the person swallow it, because they could easily pass the medication to someone else or dump
Exactly.
So
Exactly.
that also is a very uncomfortable, I think, for myself, not needing that. I don't think I would do very well with someone standing over me, hovering over me, looking down on me and saying, swallow this right now, like you're a naughty child that's not drinking your cod liver oil.
Yeah, I know. Yeah. And how did we get there? It's because we think people are hiding the medications or whatever, right? Well, and I'll give you, again, a scenario for my mom. She was getting some sort of medication, and she does have a little bit of dementia, but she's not, significant dementia. And she said to me, Heather, I think this medication is causing gastric upset. So I threw it out. So now, they found it in the garbage. So now they're hovering over her to make sure she takes her medications, right? It's like that one little incident. She's now been identified as someone who hides her medication. And rather than digging down to the root of it, why did you do that, Helen? Right? Well, it's because I thought it was upsetting my stomach and I didn't want to take it. So that's, again, we have to be a bit more person-centered with this rather than and I don't know how to get around the hovering and again, we have different types of staff in our homes in Ontario and in Canada. Those that give the meds versus those who are assisting eating are often 2 different people. And so we can't just give those meds over to the person who's assisting because of that rule of observing it, right? But we've got to figure out a way to not do the hovering. Can that RPN or whoever it is that's giving the meds sit down at the meal and give them dessert then? Right? Rather than just doing the medications. That again is an issue with time though, right? So we need to figure out our schedules such that it's not so institutional. Yeah.
Thank you. Thank you both. And I'd like to call on Eileen next to ask your question, Eileen.
Oh, thank you very much, Rosanna. And thank you for sharing all of your thoughts and views. One thing that struck me was when you're talking about socialization and group eating, that the same settings and group activity or interaction is occurring in canteens, restaurants, and workplaces, or even in schools. Yeah. And you have people who don't want to be included.
Mhm.
So how do you actually cater for that in the long-term setting?
Yeah.
Because, you know, and people want to sit in their own groups as well. So how do you generate an increased interaction? And the other thing, and just follow on the medication side of things, a lot of medication can only be taken with food, but others cannot be taken together or outside of food periods because the effectiveness of the medication. And no, has anyone done any research on that within the long-term care settings or residential settings?
I'll answer the first question or the second question first. I'm not sure if anybody's done any work around food offering and medications that should not be offered with meals. There's actually some folks that I work with who are specifically, that's their area. I'm going to ask that question to them. It's a good question because it's often, as you know, just before the meal, they're given medications. That seems to be the routine thing. But I'll ask that question of them. Back to the question though, about when people want to eat alone, even in a social space, then that's their preference. And that's what we should be providing. People should not be forced to eat at a table of four. Like a man that likes to eat alone, he maybe is a person who always worked alone, maybe a trucker going across Canada, worked alone all day long, sat at dining counters alone. That was just his way. Being in the dining room, having a place for him to eat alone can still happen, right? And there's still that social interaction around him that he observes, but he's not necessarily at a table of four people and forced to eat with some people he doesn't know. So again, that's knowing your resident and knowing their preferences, and that can still happen. And I think in that sense, the person is experiencing the social interaction the way they want to, which is by observing and listening from afar rather than being part of the conversation. I think as well, this is where the team member resident interaction is important, and knowing again, do they want to chat? I've seen in environments where some residents would rather chat with team members than other residents, right? And so recognizing that and offering, training the team members to realize this is part of the relationship building with that individual, that this is what they need and want, not necessarily talking to other residents, maybe that have hearing deficits or other challenges. They want to talk with you as a team member. And that's totally appropriate. So recognizing that's again, that person and relationship-centered care piece. Yeah.
Thanks very much, both. And next, I'd like to call upon Indu Gambhir. You have a question in the chat if you don't mind unmuting.
Yeah, thank you for your talk, Professor Keller. But my question is that we have a multicultural society. And I'm a physician, and I find when seniors revert back to their childhood language and the food. And I have looked at the homes, and it is very difficult for them to provide foods which people are used to. And how can we sort of advocate for that or help out on that? And my second question is the people, I'm just saying people because seniors also, all their life, they haven't shared their medical conditions with someone. They haven't shared what medications they are taking. And all of a sudden they find it is a general knowledge. So your idea of building relationship and trust will help. How can we do that when it is, to me, I'm looking at it is all fragmenting. The healthcare is fragmenting. Before, your family physician knew everything about, now it's not that way.
No.
So we need to bring back that sense of trust in the care provider in the homes for seniors to feel, okay, I'm not feeling today good. Can I postpone taking this medication for 4 hours or 3 hours?
Right.
They have that choice. So that's just my thought listening to you. And I'm just wondering, how can we do that? Because I have tried to work with the homes to provide culturally appropriate food, whether it is once a week or something, so that they have, and they find it very hard because they have a, how would I call it, a line of system, how they are going to do things, and it breaks that line.
Yeah. Yeah. Are you in Canada by chance, Indu?
Yes. Yes, I am in
Yeah.
Ottawa.
Well, I'd love to hear from you after this too, because I have a PhD student, as I said earlier, who's looking at cultural menus in long-term care. And her first study identified with food service managers and dietitians, they don't know how to do it. And then two, as you've indicated, the system is very constraining. Right from the amount of money we're provided in Ontario and other governments too across Canada to provide food. It doesn't allow for a lot of opportunity to buy extra foods and culturally appropriate foods. Then we have, so that's the first is the money provided. Two is the menu has to be set out. As you know, in Ontario, we're highly regulated in long-term care, has to be set out and approved, and it can't be flexed too easily. And so we have to build in those cultural things to the menu. But the people that are doing this, as we've learned from my PhD students' work, they don't know how to do it. They don't know the cultures. They don't know what the most relevant foods are to include necessarily. They may have been in school many years ago, and they weren't taught this. There isn't a course they can take about how to adapt your menu to cultures. So that's a big gap. Then the third thing is we got cooks in kitchens who've not cooked that food, don't know how to make those recipes. And then the fourth really big one is the diversity in our long-term care homes. We have many cultures, right? And so how do we try to provide something for all of those cultures? I think there are homes that are ethnocentric. They might be Asian, for example, or East Indian, and they do a better job because they have a concentration of people that eat that way. And so then they know, okay, if we provide this, that will be well accepted. The challenges in these homes where there's a lot of diversity in one single home, and how to provide a single menu to meet that, it's extremely challenging. So the student's trying to understand that a bit better and trying to move us in that direction. And she's, as I say, a PhD student. This is her area that she wants to work in. She comes from Pakistan, actually, and she's very keen to bring cultural foods into, or it might be India. She's from India, I think it is. Yes, that bring cultural foods into long-term care and senior living, recognizing incredible importance it is for the identity of people. And then your second question about medications, I totally agree, and it comes again to person-centeredness. So staff and team members knowing someone's very private. They don't want you checking their wound at meal times. That's very undignified, right? Or saying, here's your diabetes medication to the whole dining room, right? So being discreet with the way we do things is really important in long-term care. And we're often not thinking about these individuals as individuals who have pride and dignity and want to keep that. And we have to bring that back to team members and realize, how would you feel if I was staying in the dining room and said, oh, Margaret over there, here is your whatever. And the person's like, oh, I didn't want everybody to know that. So using some examples, using some case training, using some role playing, but bringing that person-centeredness into long-term care is extremely important. And people need to move away from seeing individuals as tasks, but as individuals. And it's just changing our culture, Indu, really it is.
It is. And my solution always was to tell the family, when you are going to visit at the lunchtime or supper time, and take a little bit of your food with them.
Yes, absolutely. That's a great solution.
So that was my solution after talking to many nursing home people, and I could understand their dilemma, because they needed 10 or 15 residents of the same culture to be able to provide the food, and nobody can guarantee in this age and time where they are going to be.
That is a great solution to do. And having, so then the responsibility of the home would be to know, let's put in a fridge, right? And keep it, safe. And then when someone wants to have it, it's brought out and someone knows how to heat it up, right? So that's all they need to do now, rather than creating the food itself. Great idea.
Well, thank you very much both. And just recognizing we're slowly coming close to the hour, I did also just want to ask Mr. Ralph Hubel on a very important question you had on pureed foods. Ralph, would you like to unmute to discuss this a little bit more?
Yeah, I was just curious in terms of, the people that have swallowing difficulties. How do we make that pureed food more appealing? I can remember sampling some pureed hamburger that tasted like mud, and
Yeah.
just so curious.
Yeah.
Thank you.
So certainly some commercial providers are trying to move this ahead, but a commercial food may be too expensive for some homes, especially when they have a lot of residents and it's more efficient for them to make their own food. So some key things that can be done. Rather than providing it on a plate, you can actually put the food in little dishes so then it doesn't spread across the plate. So the visual appeal is very important. I've done some work around pureed food with pureed food consumers, and they said, taste is obviously most important, but visual appeal that first time you look at it is really important too. So how can we support visual appeal? So little dishes for the pureed vegetable, for example, and then putting a garnish on that they can eat. For example, sprinkling on some paprika on, give that little red color, right, to something, and sauces that are appropriate. I've seen beef gravy put on things that beef gravy should never be put on, quite frankly, in my opinion, because it moistens the food. And so people with swallowing problems tend to have an issue with food, needs to be very moist. And if you got something that's sticky and has been sitting for too long, which can happen, of course, again, in a system that we have that is more task focused and individual focused, people then pour the gravy over everything to make it moister, right? That's not treating the food with respect or the individual with respect. So the food service needs to provide some sort of sauce that can be added to the food that is appropriate. So if it's fish, it's like a cream sauce. If it's a vegetable, it might be a cheese sauce, right? If it's a meat product like turkey, it's turkey gravy, not beef gravy. So being conscious of the fact that the food itself needs to be respected by the staff who are providing it to the older adult, but then also it respects the individual. So that's one, a sauce that's important. Garnishes like spices to make it look appropriate. Putting in dishes so it doesn't spread across the plate would be another key thing. People can add thickener to the food as well. The problem with that is it tends to dilute the taste, I find. I've tried some working with 3-day printing of pureed food. It's not ready yet. We realized the technology wasn't ready. It was too slow. But I think in the future, we're going to see people or innovations coming with how to make pureed food more appealing. So the taste has to be there, as you indicated, Ralph, right? That's really super important. And paying attention to that taste when thinking about creating the product is very important. So cooks have to be trained well. They have to work with recipes, not just assume I've got something over here that we're giving to the regular texture people, I'm going to puree it and be just fine. No, that's not the case. They have to treat that pureed product as its own unique product. And does it do well? Do they have to change the way they spice it or the way that they cook it? I did some work with a food scientist, and we identified that when you added spices after pureeing, it tastes totally different than when you added spices during the cooking process before the pureeing. So some of these things our cooks need to know so that they do a better job with creating the food. So those are just some key tips.
Thanks very much. And we are slowly coming close to the end of the session. But before doing so, I also just wanted to recognize the chat. Thank you, everyone, for posing. And I apologize if we didn't get to any specific comments or questions, including from Miss Naomi D'Souza and Oksandra Stefanuk. But thank you, everyone, for posing everything in the chat. So to conclude this session, I would really love to hear your key takeaways for us today's session, today, Heather. But before we go into that, I would like to introduce our next week's topic. So next week we have Dr. Sridhar Venkatapuram for the topic of health equity as we age. Please join us. It's going to be an incredible discussion, and I do look forward to seeing everyone there. So back to you, Heather. What are some key takeaways that you took away from this session and you would like to share with us all today?
Yeah.